Hi everyone, this is Sejal Thakur and welcome to this webinar by AAP and Osteology. And our speaker today is Dr. Anton Sculean. Dr. Sculean is professor and chairman of the Department of Periodontology and the head of the Dental Research Center at University of Bern in Switzerland. He is an internationally recognized speaker and also leads experts in periodontology. He has authored more than 600 peer-reviewed publications and delivered thousands of international lectures. He serves as the editor-in-chief of Periodontology 2000 and also is the former president of European Federation of Periodontology. He's on several major international periodontal organizations and has received numerous prestigious honors, including the IADR Distinguished Scientist Award, EFP Eminence Award, the honorary membership at the American Academy of Periodontology, and multiple honorary doctorates as well. His research focuses on regeneration, plastic aesthetic surgery, peri-implant infections, and novel therapeutic approaches including lasers and photodynamic therapy. Dr. Sculean will be sharing his insights on soft tissue augmentation today. He'll start with a short presentation, a preview from his Osteology Regeneration Symposium from the AAP 2025 meeting. And following the presentations, we'll be taking questions from the audience. So I encourage the audience to please put in their questions and we will get to it towards the end of this presentation. Dr. Sculean, it's all yours.
Thank you so much. Thank you, Dr. Tucker. I hope you can see my screen.
Yes,
Thank you very much for your introduction. And I'm truly honored for this possibility to discuss with you some of my ideas on how to treat soft tissue defects, mostly around teeth, but also in some cases around the implants. And I will discuss some of the main problems we encounter in the daily practice, and also the biologically driven concept that I try to adopt and to implement over the last 25 years. So basically, I share with you some cases, and you can observe situations where we have an attachment loss associated with difficulties in maintaining a proper oral hygiene, associated with bone loss, and in many cases, these patients have severe problems in cleaning the area, and we may even encounter some tooth loss over the time. So this is the situation, for example, to the slide at the right, of a patient who, in fact, she doesn't have a periodontitis, but due to the very thin phenotype, she was always afraid of cleaning the area. And in fact, this defect progressed, reaching the apex. And please look at this heavy calculus deposit, which makes, in fact, even tooth maintenance a difficult task. Some other cases where we have a huge loss of attachment, reaching almost the apex. In this particular case, we have a post-orthodontic situation where the patient has a huge recession due to an active retainer. And despite the fact that tooth is vital, we need to do something in order to save this tooth. Sometimes we are too late, and when the patient is referred, the tooth is already in the air. And you can see in this particular case that the central incisor is rotated outside the bony envelope, which in fact resulted in tooth loss. So for me as a clinician, what I would like to obtain is to help the patient to clean, because I focus on prevention, preventing gingivitis, preventing periodontitis, and of course root caries. The final goal is always to prevent tooth loss and, if possible, also to improve aesthetics. However, aesthetic concerns are mainly related to the maxillary arch. In some particular cases, we may treat hypersensitivity with a recession coverage with soft tissue augmentation. But these are not the main indications. Very simple question. If the patient comes with this defect in my office, what can we do? And if we build up the tissues, is it easier to clean? Of course, it is easier to clean because, in fact, we don't have this deep defect. We don't have a niche. Of course, the tissue looks healthy, and we don't have a scar tissue, at least not a visible scar tissue. So my goals are very simple. First goal is to allow and to enhance the possibility for plaque control. If possible, but the ultimate goal should be also to obtain a complete root coverage. That means up to the cement enamel junction. Obviously, this is not always the case, but this is always one of the goals. But most importantly is also to avoid the residual probing depths. So I would like to do everything possible in order to avoid the niches, in order to avoid having probing depth that exceeds 3-4 millimeters, because we know that these situations are difficult to maintain and they may result, in fact, in an infection over time. For this reason, in some particular cases, we use some regenerative materials in order to enhance the regeneration process. And least but not last, is to have a optimal tissue blending and a pleasant color without obvious signs of tissue scarring. So the treatment concept that we developed in the last 25 years is based on a wound healing situation, in fact, on the stability of the wound healing, because the phases of wound healing are always following the same pattern. And if you have a blood clot, if you have a wound, we have these 10, 15 days that are critical for the maturation phase of the wound. And in fact, everything what we are doing, keeping the tissue stable, no tension, using a graft in order to enhance the tissue stability, very precise sutures, sometimes use regenerative materials, enhance, in fact, the body's innate or have the body's innate capacity for repair and healing. For this reason, I would like to emphasize the preparation of a flap or a tunnel without vertical releasing incisions, because if you have a cut of the papilla or if you have vertical releasing incisions, obviously it is more difficult to keep this entire area stable. In difficult defects, I would like to use some biologic materials that aim to enhance periodontal regeneration, like some growth factors, some biologics. And in the majority of the cases, the problems occur due to the very, very thin tissue. So what do we do in such a case? Basically, we try to enhance tissue stability and also to provide some cells that are capable at enhancing keratinization and increasing also the tissue thickness, like a subepithelial connective tissue graft. In some particular cases, we may also increase this thickness by using some soft tissue replacement materials. And of course, the suturing technique is very, very important. We would like to have a tension-free adaptation and suturing in order to seclude this space. A very important study that I always like to mention is the role of the gingival connective tissue in determining epithelial differentiation. And as you can see, this study is older than 50 years. However, the biologic background was set in this study. As you well know, in this study, pouches were created in the mobile mucosa and different types of connective tissues were fixed to the periosteum. And in fact, the connective tissue either was harvested from the palate, where the epithelium is keratinized, or it was harvested from a non-keratinized area of the oral cavity. The tissues were left exposed, and after the healing phase, you can clearly observe the keratinized area that in fact looks like a gingiva. And in this particular case, and that particular area, in fact, the connective tissue that was fixed originated from the palate. And based on the results of this study, we know nowadays that the characteristics of the gingiva are determined genetically, and they are not the results of functional adaptation to the environmental stimuli. And second is that the specificity of the gingival epithelium is determined by genetic factors inherent in the connective tissue. So we need, in fact, this particular type of tissue in order to enhance the biologic property of the healing in the soft tissue defects. A second very important aspect is to look at the phenotype. And we have different methodologies that many authors have looked at. And with our team, we found out that when we use a very simple method, when we use a probe, and the probe is in fact transparent, then we know that if we have a thickness that is less than 0.8 millimeters. In some defect, it makes sense to regenerate the tissues, the cementum, peroneal ligament, and the bone. And one material that we like to use is the enamel matrix protein. And we know that the enamel matrix proteins are, in fact, an indirect growth factor-like material because they act on the peroneal ligament cells, and these peroneal ligament cells will produce different types of growth factors like TGF-beta, like PDGF, and they also act as a kind of biologic membrane by retarding epithelial downgrowth. You see, many years ago, we did a first study in animals where we created recession-type defects, and these defects were either treated with a coronal advance flap alone, serving as control, or a coronal advance flap with the use of enamel matrix proteins. And the histology demonstrated that following the application of enamel matrix proteins on this surface, we have a new cementum, new peroneal ligament, and new bone. And another study that we performed with our group from Japan, with Professor Shirakata, we compared the use of a coronal advance flap using a connective tissue graft around, or the combination of the connective tissue graft and enamel matrix proteins. And in the cases where we used only the connective tissue graft, we had more epithelial downgrowth, more limited regeneration, compared to the cases where we combined the enamel matrix proteins with a connective tissue graft. And based on this study, we know that the biologics could make sense. Another approach that we adopted some years ago is the use of hyaluronic acid. And hyaluronic acid has also an interesting activity because it stabilizes the blood clot. And in fact, the hyaluronic acid would attract the fibroblast from the connective tissue graft and from the peroneal ligament. And these fibroblasts proliferate significantly faster. And what they do is, in fact, to produce growth factors associated with soft tissue healing, like PDGF, like, for example, FGF2 or IGF, and they are responsible for a faster and complication-free healing. Now we tested also this material on recessions because we need to have some histologic proof if we use the material in patients. And what we did is to create recession defects, and they were treated with a coronal advance flap, either alone or with the application of a cross-linked hyaluronic acid. And the histological analysis demonstrated limited regeneration when we used flap alone. You see here some bone formation limited to the apical part of the notch. However, in the very moment we used the hyaluronic acid, we demonstrated a robust formation of cementum, peroneal ligament, and bone coronally to the notch that indicated the most apical part of the defect. Now I would like to show you our technique, the technique that we developed and we implemented, because in fact the first colleague who used a tunneling approach was Allen in 1994, but we performed the so-called advanced procedure because I perform usually full thickness preparation, and the tunnel is moved coronally after we pass the mucogingival line and we release the fibers and the muscles, is moved coronally in conjunction with the application of biologics and usually a connective tissue graft that is fixed at the cement enamel junction. And as you can see, the soft tissue tunnel is sutured coronally with simple sling sutures. And after a couple of years, we have a complete regeneration of the soft tissues. In some particular cases, we had very, very deep defects, as you can see it here. And now we have results after even 11 years. Here is the case after 4 years. And you can observe this case after 11 years, where we have a complete regeneration of the soft tissues up to the cement enamel junction. And it is very, very stable. This patient came to me a couple of weeks ago, and this is the outcome after 11 years following the use of the coronally advanced tunnel. Now, in difficult and very deep defects, especially mandibular defects, together with my very good friend, Dr. Allen from Texas, we described the laterally closed tunnel. And this technique has a number of advantages. Namely, we don't have vertical releasing incisions, we have an enhanced wound stability, and we don't have a major decrease in the depth of the vestibulum. And I would like to share with you one case, a very deep defect following a trauma. And in this case, I want to regenerate completely the tissues. What I do in such a case is to prepare a tunnel distally, mesially, and then I would like to place some enzymatic proteins on the root surface in order to enhance the periodontal regeneration process, combined with a connective tissue graft. I fix the graft and I close laterally with single interrupted sutures in order to allow for a complete healing. And I never harvest a full pregingival graft. I always use the single incision technique, and I harvest a gingival or a connective tissue graft without the epithelium layer, because this will offer a faster healing for the patient and it is much more pleasant. You can see the outcome here after roughly 2 years in indicating a complete closure of the defect, and we don't see any scar tissue formation. In very challenging cases, as you can see it here, what I'm doing is in fact to prepare a full thickness tunnel. That was a very challenging case. It is a patient following an orthodontic therapy that lasted for more than 10 years. However, the bone was completely lost, almost vestibular. We had maybe 1-2 millimeters to the apex. Also, a very, very thin bone layer lingually. So in this case, I prepare a full thickness tunnel. You can see how thin the tissue is. It's very, very important that we try our best to keep the tissue intact, not to perforate it. That's why I take my tunneling instruments and I'm staying on the bone, preparing very, very gently the tissue mesially, the tissue distally. And then a very important aspect of this treatment is, in fact, to release the fibers from the inner part of the tunnel flap, and also to go deeper. And in some cases, I release even the muscles. So in this case, I use the enzymatic proteins because this is a huge defect, reaching almost the apex. So obviously, it makes sense to use some biologics. I apply the biologics from apically to coronally on the exposed root surface. I fix the connective tissue graft using a sling suture, and after that, I will fix and close the margins from the lateral area. And I just show you the result after a couple of years. We have here a very stable situation. Now this case is 8 years old, and you see we have a complete coverage and no residual depth. And we also regenerated some of the attached gingiva. Sometimes we have some situations where we work together with an orthodontist. You see a very, very difficult case. In this case, we consulted with the orthodontist, and you can see that in this particular clinical scenario, we have a root that is, in fact, moved by the retainer more labially. In these cases, we move the teeth back. That may take a couple of months, and following the orthodontic treatment or retreatment, we have a new retainer, and then I prepare my tunnel using the lateral closure, and in this particular case, again, the connective tissue graft fixed at the cement-enamel junction using a lateral closure without any tension. And if you look at the outcome, after about 7 years, it is completely covered and we don't have any scar tissue formation. So basically, these situations are very, 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 very stable, but sometimes we have also multiple defects. And in multiple defects, we describe a specific technique that we term the laterally closed and coronal advanced tunnel. And I just want to share with you one video where we had a difficult case with recessions coming from premolar to premolar. In this particular case, I prepared the tunnel from premolar to premolar, releasing also the muscles from the inner surface. Using again the tunneling instruments, I need a very long graft. Here I harvested the graft starting from the last molar to the central incisor. And you can see that I used the single incision technique, one incision perpendicular to the bone with a 15 or 15C blade. Then I always change the blade. That's very important because we have to have a very, very smooth surface when we dissect the connective tissue from the epithelial layer. That's very important. And we always have to analyze the anatomy of the palate because in patients, especially in patients with a flat palate, the palatal artery is very close to the teeth. So we have to be very, very close with our incisions to the teeth. And we just we will publish a paper in Periodontology 2000 about the entire vascularization of the palate and of the maxillary and mandibular areas. They are very, very important. And sometimes we have also some anastomosis, especially in the area of the premolars. You have to take care of those because that's very, very important. So I take the graft, I suture then the area, I just move a little bit faster ahead. This is a specifically designed metal suture, and the graft is going to be placed in the tunnel and sutured together with a combination of a biologic material. And this biologic material is again the nematodes proteins. I pull the graft inside and then I fix it at every single tooth. And the closure is a combination of the lateral closure and the coronal advancement in order to be sure and close it completely. And just to show you the outcome after 5 years, you have a complete regeneration of the tissues, and we don't have any particular deep site. So the probing depth is in fact not deeper than 1-2 millimeters. Sometimes we need some other materials that are soft tissue replacement materials. And these soft tissue replacement materials are usually matrices based on porcine derived materials. And what we always do, if I use a certain type of biologic, this is a kind of dermal matrix, I use it in a combination with a biologic material, for example, with enematix proteins, with hyaluronic acid, or with PRF, because we know from the literature and from our own experience that, in fact, if you use a biologic in combination with a matrix, then the healing process is much more better, and we can use these matrices as a carrier for our, in fact, for our biologics, and also to attract the cells. So you see here one example where we could treat this patient without harvesting a graft. And of course, we have also some other biologics, like for example, cross-linked volume-stable collagen that we also use for this kind of defects or smaller defects. This is another type of 3D derived material that is in fact a little bit tricky to use, but it stabilizes excellently the blood clot. So I developed a technique where we insert slices of this material in the tunnel. But in this case, we need to suture the tunnel together with this material, because this will stabilize the blood clot and attract the growth factors in this area. And we can also obtain an increase of tissue thickness and a very nice keratinization. Another material that we like to use is, in fact, the so-called Novo matrix. Is in fact a material that comes from the United States, but interestingly, this material is a sewed graft. However, it is not released in your country, but we have it in Europe. So I work since, I would say, since 5-6 years with the material, and it feels very much close to a connective tissue graft. We can suture it very well, exactly as a connective tissue graft. You see here the technique that you already know. This is the outcome. So typically for this material, we have a very nice outcome in terms of color and increase in tissue thickness. In this particular case, I treated the contralateral side with hyaluronic acid combined with a connective tissue graft, because I wanted to see what performs better. And if you look now at the outcome, this is the autogenous tissue, and the other part was treated with Novo matrix. So more or less the same color, very nice outcome. And it is very difficult to say which part was treated with what kind of material. My last case relates to an implant, because we have sometimes recession of implants. Of course, this is a completely different story, but just to show you the potential of the tunneling approaches to treat recession type defects at implants. Of course, we have to have a good case. Case selection is very important, and we can discuss about that. The implant is positioned between two teeth, not outside the bony envelope. It's very important. And you see, this particular patient doesn't have any periimplantitis, no periimplant mucositis. And in this case, we have the neighboring teeth, the 21 and 23, again with recessions. She's a young lady. And we have also the 22, that's an implant with a pink ceramic. So we look at the bony level. The bone is perfect. We don't have any pathology. However, what can we do here? Because it's a huge discrepancy between the left and right side. So what I'm doing here is to prepare a tunnel, and I encompass the mesial tooth, the implant, and the distal tooth, moving the tissue coronally. I'm using a connective tissue graft. I fix the connective tissue graft at the cemento-enamel juncture of the teeth and on the implant. And then I move everything coronally with sling sutures, even more coronally than the previous level of the papilla. And when I look at the outcome after 1 year, we didn't change the crowns, we didn't do anything, we have very nice coverage, and even the black triangle, the interdental black triangles are now, in fact, improved. And I just show you another case here, before and after 5 years, using the same technique without removing the crown, and we could obtain a very nice healing. We also published this technique last year in the Journal of Aesthetic and Restorative Dentistry, indicating that we can improve and cover even completely recessions at implants with these techniques. However, we have to have a very good case selection. This is mandatory. So now let me come to some conclusions. I hope that I was able to convey to some biologic thoughts and clinical reflections on the use of the tunneling approaches, especially the modified coronal tunnel, the laterally closed tunnel, and especially in the mandibular area, the combination of both, the coronal advance and the laterally closed tunnel, to treat single and multiple defects. In difficult cases, I can recommend the use of autogenous tissue, either with or without the use of biologics. Of course, in certain cases, we can also use soft tissue replacement materials. In challenging clinical scenarios, I can only recommend go in an interdisciplinary approach to discuss it with an orthodontist, to discuss the cases with a restorative dentist, with a prosthodontist, because in this way, we can additionally optimize the clinical outcomes. Of course, you are welcome to join my Facebook group, Anton Sculean Perio Team, or to visit us in Bern, or maybe to attend one of my lectures. I will be at the AAP in Seattle in the fall this year, and I'm ready for the discussion. Thank you very much.
Thank you so much, Dr. Sculean. That was an amazing preview, and it covered teeth as well as implants. And I commend you on the fact that you showed one of the most challenging areas in everybody's mouth, which is the mandibular anterior, which is a nemesis for all of us when we are treating these cases. So we have a question here from the audience, and the question is, how long should we wait before going into the same site to harvest a connective tissue graft?
That's a good question. We don't know it precisely. However, I mean, I have to give also my personal clinical experience. I would wait for roughly about 6 months, at least 6 months, because maybe you could also go earlier, but we don't know it. There are some case reports showing that the tissue regenerates very well. And what I observed in my cases is that if you take or if you harvest a graft from the same site a second time, the quality of the graft appears to be better. You have more collagen, probably with more scar tissue, less fat, and from a clinical point of view, you can manage this graft better than the first harvest. But that's why, for example, if I have a case with multiple recessions, sometimes patients need several harvestings. So I leave the more difficult part for the last, because then the best quality of the connective tissue will be available. But of course, this is very empiric. So I don't have an RCT to support this, but I would recommend to wait 6 months, sometimes even longer.
That's a very good tip, to wait for the worst one for the end. You also kind of get an idea of how the patient's healing is by then, so I think that's
Yeah,
a great tip.
it's correct. Yeah.
Another one, I think some people want to get your Facebook group page back again. So if you want to put on the last slide for them, that would be wonderful because they want.
You just look for my name, Tony
Okay.
Sculean.
Perfect, perfect.
Okay, Perio team. Very easy.
Thank you. And one other question from the audience over here is that when you're doing decision making for tunneling and the order of the workflow, if there's a restoration required in that area, how do you manage it with the restorative dentist? Does the restoration comes in first, or is it your surgery, or afterwards, after the surgery is done, you tell them to do the restoration?
That's again a very good question. I think that the most important, is to avoid covering restorations, because you never know. Sometimes we have a cervical filling covering a huge portion of the recession, so I always like to remove it because I don't know whether we have caries underneath. I want to have full control over the situation. However, sometimes we don't see the cement enamel line
Mm-hmm.
because it is, we have also kind of abrasion. So if you want to reconstruct the cement enamel junction, what I recommend is to do it before the surgery, because you are more precise, you can dry it better, or the restorative dentist can dry it better, but I wouldn't place it over the entire recession. Try to reconstruct the cement enamel junction, also looking at the contralateral side, because we have to try to find out where was the initial CEG, to
Mm-hmm.
polish it well, and then perform the surgery, because then the emergence profile is much better.
Got it. Got it. So, one other question over here from the group is that do you worry, and you showed the most challenging area, as I mentioned, mandibular anterior, do you worry about the risk of relapse or tissue regression with tunneling procedures, especially with the mandibular anteriors? And, have you seen anything in the long term that this is the results that have been seen at 1 year, do they sustain or do they recede back after?
That's also a very, very good question, because first of all, if you look at the literature, we don't have, in fact, long-term studies on mandibular recessions, huh? And really the meat is very meager in this area. So I have now more than 1,000 cases that I'm now reevaluating, done all of them by myself. In some cases, in fact, if when I use the connective tissue, the situation became even better over time. And sometimes we can also see on a cone beam CT even bone formation over the recessions. Very interesting. So I will have some nice data maybe to show next time. It's very interesting, huh? Because sometimes you see this increase in tissue thickness in the volume, especially if you look at the tissue from the side. You push it and you have the feeling, okay, it seems hard. So I was very curious to see, and we did some cone beam CTs, even some histologies, and indeed in some cases we can demonstrate extraskeletal bone formation. So it can be stable. In most cases, it is stable. In some cases, it is even better. However, I have also to admit that I have cases where the tissue went back, not
Mhm.
completely, but to a certain extent, especially in cases where we had a so-called Miller type 3 mandible
Mhm.
recessions, and sometimes we have an additional movement of the teeth. Sometimes it decreased a little bit. I have we have some data with some soft tissue replacement materials. And in fact, I have to tell you that in the mandibular area, I was rather disappointed,
Mhm.
because with a soft tissue replacement material, the result is deteriorating in mandibular cases after 9 years, we had maybe only 15% of the results obtained at 1 year. And this may indicate that in difficult cases, go for autogenous tissue. Okay. And the difficult cases are in the mandibular area. So for me, if I treat mandibular recessions, my first choice is the autogenous tissue.
Yeah, and makes sense. It's a very unforgiving area from an anatomically,
Yeah.
challenging site if you go to see. So another question from the group here is, you mentioned about regeneration and guided tissue regeneration, and in fact, growth of bone also, as you are seeing in some of your scans, long term. So when you're thinking about guided tissue regeneration for anterior teeth, would you like to go with the approach of the connective tissue graft autogenous grafts or the traditional approach of, like, say, membrane, bone grafts, and stuff like that, GTR, to get regeneration around anterior teeth?
But we talk about recessions, right?
Yes.
Not intrabony defects.
Nope. Recessions.
No, no, no. I know clinicians who are doing that, to build a big flap. They
Yep.
raise a big flap. They put some bone graft, then they put a membrane, and they are hoping for a miracle. I have to tell you that this is, I think, is not a biologically valid concept. I mean, some would kill me now. Uh, this doesn't work,
Okay.
because this bone graft doesn't belong to the tooth. So what we need is the perontal ligament, we need cementum, and we need the bundle bone. And this bundle bone that can be only regenerated by using a biologic like PDGF or enematics proteins whatsoever, that comes from the perontal ligament surrounding the tooth. And that's why if you place a bone graft, this bone graft will not stay there. Okay, and this will disappear. We have a short-term improvement, but this will not be stable. So basically, we need biologic. We have to understand that the perontal regeneration process comes from the perontal ligament. That's the key issue and the key tissue. And we need to have the cells from a connective tissue graft that enhance, the growth of fibroblasts and enhance the formation of gingiva.
Mhm.
But using, GTR and a membrane and the bone graft, this will not work. So if you look at long-term data, this will be a failure for sure.
So you're technically using your PDL as your progenitor cell,
Yes,
you're using your connective
yes,
tissue graft as a membrane
yes,
for regenerations. Perfect.
yes.
Perfect. Somebody's put a comment here, and I think I couldn't resist myself but saying it. Great presentation. Thank you. And they're asking if you ski on that mountain behind you. But
Me,
and
me, me, not my, but my son. I took this. This is a photo I took in St. Moritz from the Suvretta Hotel. I like to be there. I'm afraid even to look down, but my son is a very good skier, so he's doing that.
another question here from the team is that when you're releasing internally and you're doing these tunnels for modified or your laterally closed tunnel,
Mhm.
are you doing a release into the periosteum, as in, is it all full thickness? Are you releasing the periosteum? Is it full, partial, combination tunnel? How are you managing the release?
That's the most important question because this is the secret of the modification of the tunneling. So I always start with a full thickness preparation because the tissue is very thin. So if you would prepare a split thickness, as most colleagues are recommending, you have a very high chance to perforate, or the tissue will become very thin, and during the healing process, you may have a necrosis. So I go down on the bone, releasing it as a full thickness flap. And once I'm in the fornix of the vestibulum, then I take my microblade and I split. In fact, it is not a perosteal releasing incision. What I do, I need an assistant who keeps the lips under tension because if the lips would relapse, then I perforate. So I need attention, and I move the blade in contact with the inner surface of of the tunnel, and that's very important. So you need a long, narrow blade that you move in contact with the inner surface, and in fact, you release the fibers, and sometimes I also release the muscles. So this is very important. So then I go with the curette, usually with the Gray C78, a mini curette, and I move the curette in contact with the inner surface of the tunnel flap, and you can immediately feel the fibers that attach. And I detach them really 3-4 millimeters. I go quite deep, so it is not minimally invasive. I call it incision free,
Okay.
okay? But it is maximally invasive, huh?
Got it.
Because you need to have really a complete tension-free area. Otherwise, the failure is for program.
Got it. We did notice that you mentioned about the preference towards a single incision approach for connective tissue graft harvesting from
Mhm.
the palate. A question from the audience is, do you ever do a deepithelialized free gingival graft, and why the preference of one over the other?
So to tell you honestly, I don't do it
Mm-hmm.
because I have several arguments for that. First of all, as you have seen, I like to have a long graft, right? Especially if I'm treating 8 recessions. So you need a graft where you harvest half of the palate. I have to tell you that is not so fun for the patient if he has a wound, a very long wound. But this is not the main argument. The main argument is that when you harvest a free gingival graft, then you have the keratinized tissue, and then you have the retipex that go into the connective tissue. So when you cut or you remove the epithelium, you can never be sure that you don't leave some basal cells, and the basal cells may lead to the formation of cysts and other problems. So there are some reports in the literature that reported and demonstrated formation of cysts, and you have maybe a nice coverage, but then the patient has some liquid formation. And
Okay.
then we have also some other studies showing we have some data in our laboratory where we showed that we don't need to remove the fat because the fat has also some progenitor cells, and these cells may convert into bone even. It's very interesting if you trigger the growth with some growth factors. So the fat is not necessarily bad, and especially when I treat mandibular recessions, and I would say maybe 80% of my cases are mandibular recessions, I want to have a thick and stable graft. So I don't remove the fat. I want to have a stable wound and a thick graft that will also act as a kind of barrier membrane and give also the cells for the healing process.
Does the adipose tissue prevent you from getting adequate adaptation on the recipient bed?
No, no, because I I use the sling sutures and I pull everything coronally and plug it to the cemental lamina junction and make the knot lingually.
Okay. And I
So
think
I
that.
sometimes do not even pass through a graft.
Mhm.
I go under the graft and I lift the entire graft coronally. And then I stabilize it at every single recession with a sling suture in order to have a complete stability. So when I move the lip of the patient, this area has to be stable. The graft should not move, because if the graft moves, then the newly formed tissue will move as well.
So I think that's the perfect segue into the next question from the audience, which is to review the suturing technique, especially for stabilizing the connective tissue graft in the tunnel that you've prepared. So just like a
Mhm.
quick review for the audience here, please.
Okay. So the first suture is to pull. It's a kind of metal suture usually. I start at one end of the tunnel, going under the papilla with the reverse part of the backside of the needle, not with the tip, because I do not want to touch the tooth or the inner surface of the tunnel. Then I use a special tweezer with a hole where I can be more precise when I place the sutures in the graft.
Mhm.
I suture the graft, then I go back first with the needle and I pull the graft in the tunnel, okay, and I pull it to one end. Then I fix it at one end, then stretch it to the other end, like a membrane. Always take care that the graft is not turning in the tunnel, because otherwise you don't have a flat surface. So I want to have a flat surface, not a kind of twisted surface, okay? And then once the graft is in the tunnel, I always start lingually. Basically, I start at the deepest recession with the reverse part of the needle. So I leave the free end of the suture lingually. Then I go buccally. I take my probe, I push my graft a little bit coronally. I go in the graft or under the graft, go back the same way I came, go around the tooth, again from buccally, come out, go back and tighten it lingually. Okay? And this is a very is in fact a sling suture. And I'm doing it at every single recession that is deeper than 2 millimeters.
Got it.
And once I fix the graft, I go and move the soft tissue coronally, or if I have a very deep recession, then I can move it laterally, because in the mandibular area, we don't have a white keratinized tissue.
Mhm.
Usually we have a more elastic-like tissue. So I can move the margins together with single interrupted sutures, or sometimes I use a modification of a double sling suture and another suture over the retainer. But it's a lateral closure, so if it is a deep and narrow defect, close it laterally, and obviously the neighboring one has to be moved coronally, otherwise you tear the papilla.
Got it. And in this way, your graft is completely independent of the flap now at this point,
Yes,
in case it is
exactly.
secured at this
Because
point.
then I have a very, very good stability. And I think this is the secret of the technique. So it's maybe a little bit boring because you need some time,
Mhm.
but in fact, I think it's a very good investment because the result will be much better.
One other question from the audience is related to patients who are going through orthodontic treatment. Is there a cutoff of age for the patients when you say, okay, let's just wait for them to completely develop or get done with ortho, and then you're going to go in and do it, or do you handle these cases prior to ortho, and at what age do you go in and do surgeries for these patients?
I mean, first of all, there's no age limit in terms for orthodontic treatment. But sometimes we have, for example, situations where we have the patient underwent orthodontic treatment, and after a couple of years, for certain reasons. Sometimes you have, the twisted retainer that for certain reasons became active. Maybe in 2 or 3% of the cases, this can happen. And then before we perform a root coverage procedure, I always consult with the orthodontist. And if they have the feeling that here is a problem with the retainer and we need to realign the tooth in the middle of the bone of the alveolar process, then they have to do it. We always take a cone beam CT, and then we can really evaluate the position of the tooth. So then we start, if possible, always the ortho treatment. I would say 95% of the cases. And then this may take between 8 and 10 months, sometimes 1 year. It depends on the case. We have a new retainer, and only then I go and I cover the recession. Sometimes you have a huge improvement just by performing the ortho treatment.
So get the tooth in a more favorable position and then stop
Exactly.
the remnant recession. And it depends
And
more on the ortho movement that they're doing.
yeah, and also to get rid of the cause,
Hmm.
because if you still have an active retainer and you perform a nice root coverage, due to the cause, I mean, you will have a relapse, and you have, yeah, then you have a problem again. So first you have to try to find out the cause, treat the cause, and then, if necessary, you perform the coverage.
So in like really young patient, I think this question is particularly meant for young patients. Like, I'm
Mhm.
thinking about teenagers. When they are going through orthodontic treatment, do you still follow the same approach as you just mentioned? Get the ortho done, get them stabilized first, and then kind of do the grafting after?
Yes. I
Okay.
mean, maybe your question um, is pointing to the need of increasing the tissue phenotype before
Um,
auto treatment.
Sometimes, yes.
So, yeah. So basically, we did a study with Professor Katsaros, and we know that, we had two groups because these studies take long time. And part of these studies are not yet published. So one group received in a skin phenotype a tissue augmentation, and the other group not. And both of them were treated orthodontically. And only 30% of the cases they developed recessions
Mhm.
in the cases that were not augmented. So for this reason, if the patient doesn't have a recession before ortho treatment, we don't automatically increase the tissue thickness, because this may end in 70% of over treatment.
Got it.
So that's why we follow the case and we decide case by case. If we have, of course, already an incipient recession and the orthodontist plans a large movement, then of course we do it, but not in every single case.
Got it. And I think this one is related to one was a big compliment to you about an exquisite presentation. So thank you so much.
Thank you.
They're asking about how deep you place your incisions, and I think they're trying to talk about how far down deep do you go with your flap elevation.
It's a good question. Until the muscles, until I can lift it completely. Huh?
Okay.
So it
And
is difficult to say in millimeters or centimeters because the patients are different.
mhm,
Sometimes you have a shallow vestibulum, you have a deep vestibulum. The most challenging cases are patients with a shallow vestibulum. And, sometimes you have the patients that have very strong muscle pull. So even it's difficult to look at them when you have the first examination, because you try to pull the lip with your mirror and it just clashes back.
mhm.
So this patient. So they are more challenging. So you need really a good assistant to pull the muscles, and then you need to release until down here. Huh? So of course, we have to be careful in the area of the premolars,
Mhm.
because there's another situation. Always take an X-ray, make sure where your mental nerve is. Some patients have one missing premolar, so it can be even more tricky. And in these cases, I prefer to prepare more in the distal area, mesially, and I never go beyond the apex of these premolars.
Mhm.
Okay, that's very important.
Another question over here is related to, I think in one of the cases you removed the composite, and it could be because of the composite being on the root surface area. When you have a concavity on that root surface, are you doing odontoplasty in that area in order to take care of flatten the root surface or treating the root surface in any form or manner before you do your soft tissue grafting?
Mhm. So basically, I like the concavities because if you want to have a stable clot, the concavity is significantly better than the convexity because you can place the graft in the concavity and it stays there. I have more problems if I have a convexity. But of course, what I always emphasize is to flatten the margins, to avoid having sharp margins, so you can flatten them. And in terms of having a restoration, as we discussed it before, I place the margin or the restorative dentist is doing that at the initial level of the cement enamel junction and polish it. Okay,
Mhm.
but I don't fill the entire cavity because I want to keep the concavity. And the
Mhm.
concavity is very useful because it will enhance the healing process. It's exactly the opposite what we would like to do.
Yep.
Basically, people would like to fill it with some composite. This is not necessary.
Mhm. It will be a good cave for your soft tissue graft to settle in over there.
Exactly. It's perfect.
Yes. Another question here is related to the type of sutures that you showed in your videos. What kind of
Mhm.
sutures are you typically using, and when are you removing your sutures?
You mean the suture material?
Yes,
It
correct.
should be a monofill. I like to use polypropylene or Prolan or it's usually non-resorbable sutures
Mm-hmm.
because I have a better stability over time. I keep the sutures in the mandibular area for at least 3 weeks.
Mm-hmm.
But if you use the Prolan or polypropylene, whatsoever, you can keep them forever. Huh? I mean, not forever, but I mean, if you take them out after 6 weeks, nothing happens.
Mm-hmm.
And if you use resorbable sutures, sometimes you still need to remove them because they give some inflammatory reactions, and you still need to remove some parts of them. And you always have more plaque accumulation, more biofilm accumulation, and more inflammatory reaction around these sutures.
Mm-hmm. And when you were talking about, eight mandibular anteriors, because I think we're focusing there a little bit more here, there are certain areas where there are aberrant frenal poles. Do you do the frenectomy more internally at the time of surgery, or are you doing it as a staged approach prior to surgery in preparation for
Mhm.
the grafting?
So what I can recommend is to never do it in a stage approach, if possible. Because the problem is that first of all, you have two surgeries, of course. So you perform the frenulectomy, you wait, and then you would like to perform a second stage of surgery. If you have one stage, two-stage approach, then you have a scar tissue. So it is always more difficult to re-enter the same site you treated before. It's more challenging to handle the tissue. So if whenever possible, do an internal frenulectomy, release everything, remove the frenulum, and then close the margins, okay, and then stabilize because the frenulum has a memory effect, okay,
Mhm.
memory capacity. So of course we need a graft, and the graft will block the reinsertion of the frenulum. And in fact, when you will look at the case afterwards, you will see that the frenulum inserts more apically and doesn't have this effect. So whenever possible, my message is do it in one stage, and the frenulectomy should be performed during the coverage procedure.
Cool. Do you ever use things such as pericryl to manage your, grafted recipient site or the donor sites, adhesives or glues or anything?
No, honestly, no, because I closed them.
Okay.
So I don't use. Some colleagues are placing some collagen in the donor area. I mean, if you like to do it, you can do it, but this will heal by itself very well.
Mhm.
But if you want to play with some collagens, you can play some collagens, close them. Is maybe more comfortable, but I'm not convinced. The most important is to close the wound and make the situation as comfortable for the patient as possible. And I don't even place some glue or whatsoever. If you like it, you can do it or use some stands.
Mhm.
But honestly, I don't do it.
Mhm.
I try to keep things simple.
Okay. We're going to take one last question because we are our time's up here. But I think the last question is a good one because they're talking about papilla regeneration. So any thought on papilla regeneration with the use of soft tissue grafting?
Oh, that's very challenging. We can make a congress about that, huh?
I know.
So first of all, papillary regeneration is not predictable. Don't trust all the guys who claim that they can regenerate the papilla. In some cases, it can be done. Um, you know, depending what kind of what was the cause of the papilla loss. So sometimes you can use a connective tissue graft, maybe also some, if you have an intrabony component, some bone substitute combined with the biologics and a connective tissue graft, and then another connective tissue graft like a wall. This can be used in certain cases. I have some cases, but I have to tell you that it is really not predictable, and I have some failures as well. Maybe I have more failures than good cases in papillary regeneration, if you want to be honest.
You're very humble. Thank you for your modesty, and thank you so much, Dr. Sculean, for a wonderful
Thank you.
presentation and a webinar. Thank you so much. Have a good day.
Thank
Bye-bye.
you. Thank you so much. Thank you for the
Bye.
invitation. Thank you. Bye. Bye. Bye.